Hello, good morning. My name is Dr. Anthony DeMarco. I am presenting a lecture to dentists, general dentists, pediatric dentists, oral surgeon, anyone that does sedation for patients that are fearful of the dentist. A little bio about me. I've started anesthesia in the 1990s. Went to medical school in Kansas City. Then did my residency in anesthesia from 1990 to 1993. From there, I went to South Philadelphia, where I spent 9 years as a staff anesthesiologist, performing anesthesia. From there, I went back to where I did my residency at Hahnemann Hospital, became associate professor and director of same-day surgery, and performed same-day surgery for approximately 2 years. And then in 2006, I started my own company, Mobile Anesthesia Service Concepts, and I've been running this company since 2006, providing office-based anesthesia for dental procedures. Today, I want to talk about providing sedation for dental procedures. What I want to discuss is one, how certain things can really cause issues in anesthesia. I will present first normal events that happen, and then we'll then talk about abnormal events. The first objective is to go over body mass index and how it affects anesthesia. Then we will go over the normals of airway anatomy. Third, we will go over three systems: the heart, the lung, and the gut, and go over what's normal and provide abnormal findings also. The fourth objective will be how we prepare our patients for sedation. And the fifth objective, we will go over events that happen that are not normal and what could possibly happen in the dental office. That body mass index is weight in kilograms divided by height in meters squared. Normal BMI, this is just a picture diagram that shows you normal BMI, overweight BMI, obese BMI, and morbidly obese BMI. Normal BMI is between 18.5 and 24.9. What I want to point out to you, a little bit of airway anatomy, is look at the circumference of the neck. As the BMI increases, you will see an increase in the neck circumference. An overweight patient, BMI is 2.5 to 29.9. Obese patient is 30 to 39.9, and morbidly obese patient is over 40. Airway anatomy. We'll show you the normal way to examine an airway to just in case we need to intubate a patient. or ventilate a patient. We want to see what we need to prepare for just in case that might happen. Normal anatomy, we are looking at a patient's mouth opening, hopefully greater than 40 millimeters. We're looking at neck circumference, hopefully less than 16 inches. We're looking at the flexibility of the neck, where the patient can flex and extend properly. And then we're looking at what's called Malampati classifications. Class 1 is when you can see the uvula and all the way back in the larynx. Class 2 is when you see half the larynx and part of the vocal cords. In order to intubate a patient, nowadays what we use is a video laryngoscopy. I specifically use air track video laryngoscopy because I feel like once I see the vocal cords, placing the tube is much easier than the other video laryngoscopy. But we're going to show you a video of a McGrath laryngoscopy. Here's the air track. You can see here, you can see the vocal cords opened. And the nice thing about the air track is once you want to place the tube, it guides the tube into the vocal cords. McGrath does not. So let me show you a picture or a video of the McGrath. Unfortunately, the video is not working on the McGrath version of intubation. We're going to move on to understanding systems and functions in anesthesia. We're going to look at a normal heart. The rate of the heart is 60 to 100 beats per minute. A normal heart has a rate of 60 to 100 beats per minute. The blood pressure is usually 120/80. The cardiac output is the heart rate times stroke volume. Stroke volume is preload, which is the venous return. Contractility, as you can see the heart moving. And then afterload, which is pushing the blood out into the rest of the system, up into the heart, down the aortic aneurysm, and this is what cardiac output is. Cardiac output is heart rate times preload times contractility times afterload. With a normal heart rate, what you see is you will see contraction of the ventricles and filling of the atrium. And you see that in normal sinus rhythm. You also can see it in ventricular tachycardia. When you don't see contraction of the ventricles and filling of the atrium, or contraction of the atrium, filling of the ventricles, is during rhythms such as ventricular fibrillation or asystole. Normal lungs. A normal lung, the pulse oximeter will be above 90. That's a normal lung. The airway, the anatomy of a normal lung, you can see that the airway starts from the mouth and the nose, goes down into the cricoid cartilage where the vocal cord is housed, down into the trachea, down to the bronchi, bronchioles, and the end point is the alveoli, where gases exchange. You have exchange of carbon dioxide and oxygen. They're the primary exchange of gases. The other thing that's important about your normal oxygenation is how do you take a deep breath. And this occurs with this big muscle called the diaphragm. The diaphragm is what moves, once you're taking a deep breath, it moves downward. Now, in a person that has obesity, overweight, obesity, and morbidly obese patients, the diaphragm, because of the visceral fat, cannot move as well. And since the diaphragm can't move as well, you don't get a complete inhalation of oxygen, which states that your reserves that you have for reserving oxygen is lower. As you look at a obese or a morbidly obese patient, we have a syndrome called oxygen obesity hypoventilation syndrome. The old term used to be Pickwickian syndrome. Pickwickian syndrome is usually a BMI greater than 30. The awake arterial carbon dioxide is greater than 45. Usually an obese and morbidly obese patient has a difficult airway, but they also have a reactive airway. Their lung functions are reduced because of the diaphragm being restricted by the visceral fat. Also, patients that are obese usually have heart disease and some type of diabetes. When you look at diabetes, one of the main criteria for doing a dental procedure is how good is their hemoglobin A1C. You're always looking for a hemoglobin A1C of less than 8. That demonstrates that your probability of healing is improved. Hemoglobin A1C of 9 and greater, because of microinfarctions caused by diabetes, healing will be reduced. The other thing that happens with a morbidly obese patient is they have a delayed gastric emptying because of that visceral fat that gets in the way. Talking about just the vocal cords and the anatomy, where the vocal cords are, and we will then also talk about normal, and then we'll talk about the abnormal, where we see laryngospasm. But let's first talk about the normal airway. In pediatrics, the cricothyroid is flexible, the epiglottis is floppy, and the vocal cord is usually at the level of C3, C4. An older adult, the vocal cords are usually at the level C5, C6. Cricothyroid is more rigid, and the epiglottis is not as floppy. As you can see from the other picture of the vocal cord, that vocal cord is wide open. When you have mucus or blood or saliva or water touching the vocal cord, it causes a spasming of the vocal cord that we can see in this picture. And when that spasming occurs, exchange of air through the vocal cord could be very little or non-existent. When it's a little bit of air, you'll hear a high pitch squeaking of air exchanging either inhalation or exhalation. In order for us not to deal with this problem, and especially during allergy season, what we do is we will give medications to try to dry up the airway, such as Benadryl, Robenal, Mucinex, Allegra, and Afrin. Again, causes of laryngospasm are fluids: blood, saliva, water, and mucus. In order to prevent this from happening while we're doing sedation, we will place a throat pack or use an isolate that can pick up secretions and fluids. And we will make sure that the level of sedation is light to moderate so that the patient can maintain their airway. Patients that have a normal airway, you'll see an exchange of oxygen and carbon dioxide with having no problem. When a patient has a reactive airway, such as chronic obstructive pulmonary disease or asthma or allergies, or if they smoke tobacco or marijuana, or they vape, what happens is that during exhalation, obstruction occurs, and there is not really good exchange of gases during that time. When there's really poor exchange, you will start to hear audible sounds such as wheezing or something that sounds like loose water in the lungs, which is called it's wheezing, but it's like a bronchial type of sound. Let's go over normal steps of digestion. The GI tract starts at the mouth, breaking down food. We break down food in the mouth. It goes down the esophagus into the stomach, where it is further broken down because of the acid that is in the stomach. pH is usually less than 2.5. Once the food is broken down, it will then bypass into the small intestines where nutrients are absorbed. We're going to have maximum absorption of food in the small intestines. Whatever is not absorbed will then go through the large intestines, and there we will have those byproducts absorb water and create feces, which will then empty into the rectum. Why is the gut so important? In anesthesia, especially with oral sedation, we worry about vomiting. And what happens during vomiting if you're sedated? Well, remember, again, I talked to you about when food is broken down, it's broken down in the stomach, it's very acidic. The pH of the stomach can be anywhere from 1.5 to 3.5, and normal pH is 7.0. And when patients vomit, that content can go up into the esophagus, come out, and possibly go into the vocal cords. Our epiglottis, which tries to block anything getting into the lungs, will try to prevent it, but material can get in if the epiglottis is out of the way and gets into the vocal cords. And then that material, which is very caustic, will get into the lungs and damage the lungs. We can see an increased risk of aspiration with obesity or patients that are using GLP-1s. And in anesthesia, what we do is we try to get the patients off GLP-1s for 1 week prior to the procedure. MPO status, nothing per os. For clear liquids, we do 2 hours before a case. For babies that are breastfeeding, we do 4 hours. If cases are done later in the day, we'll have patients not eat or drink anything for 6 hours, and we'll tell them to have clear liquids with toast. And then we will see them in the afternoon. When patients are having procedures in the morning, usually we tell them 8 hours. If patients are obese, we will increase the time because remember, you have delay in gastric emptying with patients that are obese. So we'll tell them 12 hours in some cases. Okay, now that we've gone over 3 of the systems that we see normal in some abnormal situations, I want to just go over what we do when we get patients ready to go for a dental procedure. First thing we do is we actually contact the patient 2 to 4 weeks prior to the case, and we review their height, their weight, surgeries that they had in the past, their past medical history, their social history, such as do they smoke, do they drink every day, are they doing any recreational drugs, what medications are they taking presently, do a superficial dental exam, see if anything's loose, cracked in the mouth that could fall out while we're sedating. And then we will also, if patients have a positive medical history, we will end up getting clearances and or lab results. How we have lab results done is we have actually the dental offices doing it. They go to our website, massdental.com. On there is a document finder which helps people that are non-medical people be able to pick out labs and clearances for the patients using the document finder.
Welcome to this instructional video on how to use the Mask Dental Document Finder feature. This tool was designed to help non-medical staff and dental support teams quickly identify which patient pre-operative requirements are needed before scheduling anesthesia services with Mask Dental. The document finder begins by asking you to select one of 3 patient types. Number 1, no medical or psychological problems. Number 2, no medical or psychological problems but age 50 or older. Number 3, has medical conditions. If you select no medical or psychological problems, you'll be informed that no preoperative tests or clearances are required for this patient before their dental service. If you select no medical or psychological problems but is 50 or older, the document finder will indicate that an EKG within the past 6 months is required prior to treatment. If you select has medical conditions, you'll be presented with a list of moderate to severe systemic diseases. Read through the list carefully and select yes for each condition that applies to your patient. Once you've made all selections, click View Results. The results screen will display a patient profile summarizing all selected conditions, followed by a detailed breakdown of required items grouped into 3 categories: PCP clearance, blood work, and other tests and clearances. At the bottom of the results page, select Generate Lab Order Form. This will compile all necessary prescriptions and lab requests into a PDF download for your patient. Before downloading, a patient information window will appear. Enter the patient's first and last name, date of birth, phone number, and full address. Then click Generate PDF. If generated successfully, you'll see both a confirmation notice in your browser and a PDF file automatically downloaded to your computer's download folder. Thank you for using the Mask Dental Document Finder, the easiest way to determine preoperative requirements and grow your dental practice without the overhead. Welcome to this instructional video on how to use.
After we collect all the data that we need, then and during the interview process, then we will talk to the patient about the day of surgery and what will happen that day. We take them through the whole sequence from the time they come into the office to the time they go to sleep. And we go step by step about what will happen, getting them prepared to go to sleep. So let's review the difference between three types of sedation. There is, the first two types are mild and moderate. In these situations, mild, you're minimally sedating the patient and trying to reduce their anxiety. Okay, but under this state, patients are just profoundly relaxed and a little sleepy, but they remain fully conscious and they'll be able to follow commands. During moderate sedation, their minimally depressed level of consciousness used for the procedure. The patient remains awake, they breathe independent, they'll respond to verbal commands while feeling very relaxed and pain-free. We'll have some memory loss. That's the difference between mild and moderate. And then heavy sedation is what mobile anesthesia service concepts usually does for the dentist. We actually are putting the patient to sleep. They lose their airway reflexes. So that's why we have to put a throat pack in there. But the patient is not involved in the procedure. They don't move during the procedure, and allows the dentist to do the procedure without having to really engage with the patient. It allows the dentist to focus more on the procedure while we are focusing on the patient. The types of oral sedation that's used for minimum and moderate sedation in pediatrics today is usually midazolam. And it's used between starting 6 months and older. And when we think about pediatrics is 6 months and older up to puberty. Once you go through puberty, you're now physiologically an adult. Midazolam for pediatrics, we're using anywhere from 0.25 to 5 milligram, 0.25 to 0.5 milligrams per kilogram per dose. You're giving this 20 to 30 minutes before the procedure. Used to use chloral hydrate. It is not available anymore. In adults, we'll use three types of benzodiazepines. One is Halcyon, the most favorite oral medication used by dentists for oral sedation. Also, there's Ativan and Valium. The typical dose for Halcyon is 0.125 to 0.5 milligrams, given about 60 minutes prior to the case. The half-life is an hour and a half to 5.5 hours. Especially in older patients, you will see that the half-life will be longer. Sometimes with Halcyon, nitrous oxide is used also. Again, you still need to maintain, with this oral sedation, mild to moderate sedation. And in mild to moderate sedation, the patient must be able to maintain their airway. So what can go wrong? We can see incidents with obesity go wrong. In heart rate, we'll see that, and also in airway. Case one is a patient that uh, ex IV drug addict, um, and start the case. Just want to go over this case again. This is a 43-year-old male having his upper and lower teeth extracted, implants placed, and having dual arch placed. The gentleman had no other medical problems except that he was a history of IV drug abuse. So this is what I saw. We started I went into the room and started his IV, gave him EKG, blood pressure cuff, pulse ox, started the IV, put him off to sleep, and then once he was placed to sleep, I saw this happen. At this point, once I saw this, he actually started back up again, and his heart rate was fine the whole case. His blood pressure was good. We did the whole case, but he came back 3 months later. They were uncovering his implants, and he had the same rhythm where he actually, his heart stopped. We sent him to the cardiologist. We found out later that actually he stopped using heroin, and he was actually snorting heroin. He stopped snorting heroin, and what he did was he started snorting cocaine. And this is what he was doing to his heart. He was damaging his heart. Next case, we had a 67-year-old.
Let's take a look at sinus bradycardia. It's a heart rhythm that's just, well, slower than normal. Okay, check this out. You've got normal on the left and bradycardia on the right. You can literally see how the heartbeats are way more spread out. That's the dead giveaway.
So what's normal? We're talking a steady rhythm somewhere between 60 and 100 beats a minute.
And this right here, this is what that baseline electrical activity actually looks like. Nice and steady.
But with sinus bradycardia, things slow way down. The rhythm drops below 60 beats per minute.
And you can see it plain as day on the EKG. Just look at that space between each spike.
How slow are we talking? Sometimes it can drop way down into the 30 to 40 BPM range.
So what's going on? Your heart's natural pacemaker, the SA node, is just firing a bit slower. But here's the key. The electrical signal itself, it's still traveling through the heart perfectly fine. What's really interesting is that, besides being slow, the EKG actually looks pretty much normal. The rhythm's regular, and you've got all the right parts of the wave showing up.
We can even figure out the exact rate by counting those little boxes between heartbeats. Like in this example, 50 small boxes means your heart rate is down at just 30.
Let's break down the wave real quick. First up, the P wave. That's the atria contracting.
And right after, you get that big QRS complex. That's the ventricles doing all the heavy lifting.
So, is this a bad thing? Well, for a top athlete, it might just mean they're in amazing shape. But if it gets too low, that's when you start getting symptoms like dizziness or even fainting.
And let's be clear, severe cases are a real medical emergency. No messing around.
So what's the tipping point? When does it become an emergency? It's not just about the number. The real danger is when the heart can't pump enough blood to the body. That's the critical point.
Let's take a look at sinus bradycardia. It's a heart rhythm that's just, well, slower than normal.
Okay, check this out. You've got normal on the left and bradycardia on the right. You can literally see how the heartbeats are way more spread out. That's the dead giveaway.
So what's normal? We're talking a steady rhythm somewhere between 60 and 100 beats a minute.
And this right here,
sinus
this
rhythm.
is what that
So
baseline
what I
electrical
did
activity
was
actually looks
I
like,
gave a
nice and steady.
medication
But
that
with
would
sinus
actually dilate all
bradycardia,
the
things
veins and
slow
arteries.
way
By
down.
doing that,
The rhythm
the
drops
blood
below
pressure
60 beats
dropped
per
to
minute.
105/51,
And you can see it plain as day on
and
the
the heart
EKG.
rate went
Just look at that
from
space between each spike.
35 to 40
How slow are we
to
talking?
70 to
Sometimes it can drop
75
way
beats per
down
minute.
into the 30 to 40 BPM range.
And this
So what's
is
going
an
on?
example
Your heart's natural
of
pacemaker, the SA node,
autoregulation,
is just
how the
firing a
body
bit slower.
tries to stay
But
in
here's the key.
homeostasis.
The electrical signal
Blood pressure
itself,
goes up,
it's still traveling
heart
through the
rate
heart
drops.
perfectly fine.
If
What's really interesting
heart
is that,
rate,
besides being
if blood
slow,
pressure
the
drops,
EKG actually
the heart
looks
rate goes up,
pretty much
and it's
normal.
looking to stay
The
in
rhythm's regular,
homeostasis.
and you've got...
So in case number 3, this is a pediatric case. We just wanted to go over bradycardia in a pediatric case. When you have a pediatric case with bradycardia, your first thought is, are they oxygenating and ventilating properly? Hypoxic, which is a low oxygenation to the tissues, or hypoxemia, low oxygenation through the arteries, is a telltale sign, and what you'll see is you will get heart rate to slow down if you're not ventilating properly. Also, if you're intubating, there's a lot of nerve endings in the vocal cords, so, and the vagus nerve is right there. So if you're intubating, sometimes you can cause a bradycardia in a child. Remember, there's more parasympathetic tone in the child than in the adult. Case 4, this is just to show you extreme high blood pressure. And over time, what you can see is you can see a thickening of the left ventricle with severe high blood pressure. The other thing that happens with severe high blood pressure, again, it's pressure pumping through pipes. The pipes in our body are our artery and veins. If the pressure is so high, you can burst a pipe, just like you can in a drain. So bursting of the pipe you can usually see in your head as a stroke. You can see it in your heart. You can actually get a heart attack from that, and you can actually damage your kidneys where your kidneys stop function. So blood pressure this high is, you should not be doing a case. You should stop the case, and the patient should go to his primary care or cardiology and get the blood pressure taken care of, controlled to normal, 120/80. The last case that we do, sometimes we do very, very sick patients with heart disease. This patient had an ejection fraction of 25%. Normal is 50 and above. Patient also had 3 stents in his heart and was a smoker for 50 years. We did this case, but we did this case not under heavy sedation, but more moderate sedation. And we watched this patient's heart rate, blood pressure, and his oxygen saturation to make sure that he was good. He was coming for a double arch. Again, he got all his teeth extracted, got 12 implants placed, and then had the next day had the arch placed. Thank you very much for listening to this lecture. I'm hoping to have more lectures in the future. Thank you.